if you're listening to this, you're likely tired of leaving doctors' offices with more pamphlets than actual answers.
Yeah, that happens a lot.
Right. You want to be thoroughly informed about endometriosis without just, drowning in all that medical jargon. And most importantly, you want to know what your options actually mean for your daily life.
Exactly, because usually, I mean, when we think about modern medicine, we expect a simple equation.
Like you have an infection, you take an antibiotic, it goes away.
Right. We really crave that definitive one-size-fits-all cure. It's what makes the healthcare system feel predictable.
But if you're navigating chronic pelvic pain and endometriosis specifically, you already know that straight line is a total myth.
Oh, absolutely.
Treating this disease is, it's way less like a simple math problem and much more like trying to navigate a labyrinth in the dark.
That's a really good way to put it.
Which is exactly why we're doing this deep dive today. We're looking at the brand new 2026 Clinical Practice Guidelines on Endometriosis.
Yeah, published by the SOGC, the Society of Obstetricians and Gynaecologists of Canada.
So our mission today is to sort of decode the two most critical crossroads in managing this. First, navigating that incredibly complex menu of hormonal therapies to find what actually works for your body.
Because it is a massive menu.
It really is. And second, we are unpacking the blueprint for preoperative counseling because, if surgery becomes necessary, that conversation you have before you ever go into the operating room is going to shape the rest of your life.
It's huge. And, the overarching theme of these 2026 guidelines is really about taking back control.
Yeah.
The era of a doctor just handing you a prescription pad and saying, like, check back in 6 months, that's ending.
Thankfully.
Yeah. These guidelines are pushing for a model where knowledge and clear communication are your best tools. So to be an active partner in your care, you have to understand the mechanics of the options in front of you.
Okay, so let's unpack those mechanics.
Yeah.
To understand how to treat endometriosis, we first have to understand what fuels it, right?
Yes, estrogen.
Estrogen. So the primary fuel source for these lesions growing outside the uterus is estrogen.
Exactly. And because the disease is so heavily estrogen dependent, the foundational step for managing the pain is usually hormonal suppression.
You're essentially trying to starve the disease of its fuel.
Right. And that biological reality brings us to what the SOGC guidelines establish as the golden rule of medical management.
Which is?
There is no single formulation that is objectively superior to another across the board.
Wow, so no magic bullet.
No magic bullet at all. The choice of treatment has to be guided by, well, a specific triad of factors. First, your personal preferences. Second, your comorbidities.
Meaning like other health issues?
Yeah, just the medical term for anything else you might be dealing with, like migraines or high blood pressure.
Okay, got it.
And then the third factor is your disease phenotype.
Disease phenotype. So how the disease is actually physically presenting and spreading inside your pelvis.
Right. And that phenotype piece is crucial because it explains why a treatment might work for one person, but just completely fail for someone else.
Like, for instance, the guidelines mention combined hormonal contraceptives, your standard birth control pills with estrogen and progestin.
Yeah, those are often a great starting point for initial pain relief.
Because they flatten out the hormonal spikes of a normal cycle, right?
Exactly. But the guidelines also note they're significantly less effective for patients who have deep endometriosis.
Okay, let's define deep endometriosis because that seems to completely change the treatment landscape.
It really does. So superficial endometriosis is kind of like a scrape on the surface of your skin, right? The lesions just sit on the surface of the pelvic lining.
Okay.
But deep endometriosis, it behaves much more like tree roots. It infiltrates deeper than 5 millimeters into the tissue.
Ouch.
Yeah. And it often invades organs like the bowel or the bladder.
So it's really dug in there.
Exactly. And those deeper established lesions sometimes develop the ability to, well, produce their own local estrogen. Or they become resistant to the hormones in a standard combined pill.
So the standard pill just isn't strong enough to starve those deep roots.
Right. It just can't touch them.
Which brings up a fascinating strategy in the guidelines for when a treatment stops working. Like, let's say you've been on a combined pill. You've been fine for a year, but now the pain is creeping back.
It's a really common scenario.
My instinct, honestly, would be to ask my doctor for a higher dose.
Yeah.
Or maybe just switch to a different brand of pill.
Yeah, that's what most people think. But the recommendation is actually to switch to a completely different class of drug altogether.
So is this like changing the locks on a door? Like, if estrogen is the key, turning the lock and fueling the disease, and the pill stops blocking the keyhole. You just need a drug that changes the lock entirely.
That is a highly accurate way to visualize it, actually.
Right.
Yeah, because these different classes of medications, they target entirely different receptors in the body. If your body has adapted to the combined pill, if it's figured out how to pick that lock, essentially hitting it with a different brand of the same drug class just won't do anything.
You need completely new hardware.
Exactly. So you might move to an oral progestin-only pill like Dynagest?
Dynagest, okay.
Yeah, which actively binds to progestin receptors to thin the uterine lining. It creates this really highly hostile environment for those lesions, forcing them to shrink.
I noticed the guidelines also talk about a device that could be physically inserted into the body to deliver these progestins, like often right in the OR during surgery.
Yep.
How does that work compared to just taking a pill every day?
So you're thinking of the levonorgestrel intrauterine system, or the LNG-IUS.
Right, the IUS.
Yeah. It's a small device, and it contains 52 milligrams of a progestin hormone. The big strategic advantage here is localized delivery.
Localized meaning it doesn't go everywhere.
Exactly. Oral pills require systemic absorption. They have to travel through your digestive tract into your bloodstream and circulate through your entire body just to finally reach your pelvis.
This seems really inefficient.
It is. But the LNG-IUS is placed directly inside the uterus, so it delivers a concentrated dose of hormone exactly where it's needed.
So it thins the lining and suppresses the local environment, but probably with fewer systemic side effects, right?
That's the goal. Yeah.
But, okay, there is a massive caveat with this device that caught my eye in the source text.
Oh, the timeline issue.
Yeah. So the LNG-IUS is approved as a highly effective contraceptive for up to 8 years.
Right.
But the guidelines issue this very specific warning for endometriosis patients who rely on it for pain management.
Yeah, because the release mechanism of the device isn't perfectly flat over a decade.
It drops off.
It does. The amount of hormone it releases daily slowly declines over time. So by year 6, it's still releasing more than enough hormone to prevent a pregnancy. But it might not be releasing enough to keep the endometriosis suppressed.
Wow. So because of that declining rate, patients might find their pain returning years before the device officially, expires.
Exactly. So in those cases, the patient might need the device replaced early, or they might need an oral medication kind of layered on top of it to suppress ovulation again.
It really sounds like a constant recalibration.
It is. It's never just set it and forget it.
And altering the body's baseline like this, it doesn't happen in a vacuum. Every medical intervention has a cost.
Absolutely.
If we are changing the locks and starving the disease, we also have to look at the collateral damage, which means comparing the side effect profiles of these drugs.
And this is exactly where shared decision-making has to start, because if you move past the combined pills and standard progestins, you run into the heavy hitters.
The big guns.
Right. The GnRH antagonists like elagolix and the GnRH agonists like leuprolide.
And how do these work?
They work by shutting down the brain's signal to the ovaries entirely.
Whoa. Entirely.
Completely. They essentially put the body into a state of medical menopause to aggressively and systemically starve the endometriosis of estrogen.
Putting a 25 or 30-year-old into temporary menopause sounds incredibly intense.
It is a massive shift for the body.
And the guidelines emphasize the need for something called add-back therapy for anyone on these specific drugs. But the mechanism here sounds, completely counterintuitive to me.
How so?
Well, you take this heavy-hitting drug to shut down estrogen production completely, but then you take an add-back pill to put a small amount of estrogen right back into your system.
I know, it sounds weird.
Why go through the trouble of suppressing it just to add it back?
Okay, so it relies on something called the estrogen threshold hypothesis.
Threshold hypothesis, okay.
Yeah. Different tissues in your body require different levels of estrogen to survive. So endometriosis lesions require a relatively high level of estrogen to grow and cause pain.
Yeah.
But your bones and your brain, they only require a very low level of estrogen to stay healthy and function normally.
Oh, I see.
Right. So the GnRH drug drops your total estrogen to 0. The add-back therapy just trickles enough hormone back in to protect your bones and, prevent severe hot flashes.
But crucially, it keeps the overall level below the threshold that would wake up the endometriosis.
Exactly. It's a very precarious, highly calculated tightrope walk.
That is fascinating.
Yeah.
Speaking of calculated risks, I want to ask about a drug mentioned in the historical context of these guidelines, danazol.
Oh, yes. Danazol.
It's an older medication, and the text notes it's highly effective at reducing pelvic pain, but it's rarely used today.
Yeah.
What is the biological mechanism making doctors shy away from it now?
Well, danazol is a synthetic steroid,
Yeah.
and it's actually derived from ethistrone, which has properties that are very similar to testosterone.
Oh.
Yeah, so it's incredibly effective at suppressing the ovarian cycle, but because it acts similarly to a male hormone in the body, the side effect profile is severe.
Like what?
Patients can experience significant weight gain, severe acne, a permanent deepening of the void, and a decrease in breast size. And furthermore, if a patient were to accidentally become pregnant while taking danazol, that testosterone-like mechanism crosses the placenta.
Oh, no.
Yeah, it can cause virilizing effects in a developing female fetus, meaning the fetus could develop male physical characteristics.
That is a staggering risk profile. It makes complete sense why a provider would look for alternatives.
Absolutely.
But let's look at a side effect that is common across almost all of these modern estrogen-suppressing therapies, the impact on bone mineral density.
Yes, BMD.
The guidelines note that these therapies typically cause a 1 to 2% drop in bone density over a 6 to 12-month period. Now wait. If I'm a patient and a scan shows I am literally losing bone mass, my first instinct would be to stop taking the drug immediately to protect my skeleton.
Of course.
So why is the guideline telling providers to hold the line?
That instinct to protect yourself makes complete sense. And honestly, it's a major reason why patients abandon these therapies. But this is where we have to look at how the medical data is actually collected. Okay.
The SOGC guidelines provide some vital context here to prevent unnecessary panic. First, this minor bone loss is partially reversible within 6 months after you stop the treatment.
Okay, that's reassuring.
But the bigger issue is how we measure that loss. We use DXA scans, which use low-dose X-rays to measure bone density.
So a DXA scan takes an X-ray picture of the bone, calculates the density, and gives you a number. Why shouldn't we trust that number?
Because a DXA scan only measures the quantity of the bone.
Just the quantity.
Right. It tells you how dense the material is. It cannot measure the quality or the microarchitectural strength of the bone itself.
Oh, wow.
Yeah. A slight drop in density doesn't automatically mean the bone is brittle or going to fracture. And furthermore, there is a massive methodological limitation with the DXA machines themselves.
What do you mean?
According to the U.S. Preventive Services Task Force, you need a minimum interval of 2 full years between scans to detect a truly meaningful, statistically significant change.
Yes. The machines simply aren't precise enough to make definitive conclusions over a short 6-month window.
So the clinical trials that report this 1 to 2% drop over 6 months, they're essentially trying to measure a millimeter of change using a yardstick that only has inch markers.
That is exactly the issue. The tool just isn't built for that tight of a time frame.
That completely changes how you look at those numbers.
It does. It moves that side effect from a point of immediate panic to a point of long-term monitoring. And we see a very similar need for context when it comes to mood changes.
Right, because patients often read the warning labels on these hormonal drugs and fear they'll cause severe depression.
Which is a valid fear.
Very valid, considering how intimately hormones are tied to our brain chemistry.
It is. But the guidelines clarify something important. Endometriosis patients are already at a baseline higher risk for mental health disorders.
Because they're in pain.
Exactly. Simply living with chronic, ignored pain rewires your nervous system and degrades your quality of life. But the clinical trials show the actual risk of these specific medications directly causing new onset depression is quite low, usually under 5%.
Okay.
For a vast majority of people, the psychological relief of finally suppressing chronic, debilitating pain actually results in a significant improvement in their overall mood.
Wow, so treating the pain treats the mood.
Often, yes.
But what happens when the pain doesn't stop? Because hormonal therapies are foundational, but they're essentially a holding pattern, right?
Basically, yeah.
They manage the symptoms, they suppress the growth, but they do not cure the underlying disease. If the medical management fails, or, if a patient's trying to get pregnant and obviously can't take birth control pills, we have to pivot.
We pivot to the operating room, and the guidelines are very rigid here. Surgical indications must be clearly defined.
What are the main ones?
We're talking about refractory pain that ignores all the medications we just discussed. Infertility cases. Or, most critically, we're talking about organ dysfunction caused by deep endometriosis.
Yeah, the guidelines specifically warn about something called silent renal death, which is it's an incredibly dark medical phrase.
It is a terrifying reality of the disease.
How does endometriosis silently kill a kidney?
It goes back to how deep endometriosis infiltrates tissue. The lesions can grow on and around the ureters. Those are the delicate tubes that carry urine from the kidneys down to the bladder.
Okay.
As the endometriosis bleeds and heals cycle after cycle, it creates dense scar tissue. And that scar tissue can slowly wrap around and constrict the ureter like a vice.
Oh my God.
Because it happens so gradually, the patient might not feel acute sudden pain, but the kidney silently backs up with fluid, swells, and eventually loses function and dies.
That is horrifying.
It is, and deep endometriosis can do the exact same thing to the bowel. It infiltrates the intestinal wall and can cause a severe, life-threatening obstruction.
So in those cases of severe organ involvement, the guidelines lay out a strict rule, right? Identify, stabilize, and refer.
Yes. You use the heavy-hitting medical suppression to halt the disease growth, and you get that patient to a specialized center of expertise immediately.
Which brings us to the most critical juncture in this entire process. If you are a patient sitting in a doctor's office and you realize the pills aren't working, or a scan shows a cyst threatening your ovary,
Sure.
making the jump to surgery is terrifying.
Completely terrifying.
Yeah.
Because the stakes involve potential loss of fertility and severe surgical complications.
Right.
The conversation you have before they ever put you under anesthesia is arguably just as critical as the technical skill of the surgeon holding the scalpel.
And the guidelines devote a massive amount of space to this. Recommendation 9 and Box 2 lay out this highly detailed blueprint for preoperative counseling and shared decision-making.
It's extensive.
It makes it clear this cannot be a generic, rushed conversation in a hallway. It has to be highly individualized to the patient's actual life.
Exactly. This surgical plan for a 28-year-old who is trying to conceive in 6 months is going to look vastly different than the plan for a 45-year-old who's done having children and just wants the daily agony to end.
Right. And the surgeon's primary responsibility in that room is managing expectations, right? Outlining expected outcomes.
They have to be honest. Predicting exact pain relief after endometriosis surgery is incredibly complex. Removing the lesions does not guarantee the pain pathways in the nervous system will immediately quiet down.
It reminds me of the conversations you have to have before a massive home renovation.
How so?
Like, you hire a contractor to knock down a wall, but they explicitly tell you, we don't know what's behind the drywall. If they find faulty electrical wiring or a cracked pipe, you need to agree on exactly what they are allowed to do about it before they swing the sledgehammer.
That's a perfect analogy. That really grounds it because shared decision-making goes way beyond quickly signing a generic consent form on a clipboard. It is a values-based partnership. If the surgeon opens your pelvis and finds that the endometriosis has deeply infiltrated your bowel, what is the plan? Think about what it means to be told you might wake up with a temporary ostomy bag.
That changes everything.
It alters how you plan your physical recovery, how you manage your job, how you lift your kids. The guidelines say this cannot be a footnote. It has to be a dedicated conversation.
And Box 2 explicitly outlines these material risks that must be shared.
Yeah.
Infection, injury to the bladder or blood vessels.
Yep.
And if you have ovarian cysts, endometriomas, the surgeon has to discuss the reality that carefully peeling that cyst off the ovary could inadvertently remove healthy ovarian tissue.
Which compromises your ovarian reserve.
Or even leads to early sterilization.
It is a profoundly heavy conversation to have, but it is entirely necessary so that there are absolutely no surprises when you wake up in the recovery room.
Definitely.
And crucially, the guidelines mandate discussing the alternative. What happens if we do not operate?
Right, because doing nothing is still a medical decision. If you decline surgery, the pain could progress. You could face further loss of fertility. Or that ureteric nodule we talked about could completely choke off the kidney.
Right.
The guidelines stress that all of this, the risks of acting, the risks of waiting at all, must be heavily documented.
Heavily documented.
And it has to be personalized. And ideally, this informed consent discussion should be provided in your primary language, using professional translation services if necessary, just to ensure nothing is lost in translation.
It's all about ensuring the patient remains in the driver's seat of their own bodily autonomy, even when they're asleep on the operating table.
It is incredible how rigorous this roadmap is when you actually break it down.
It's a huge step forward.
It really is. So to bring all of this together, we've explored the two main pillars of the 2026 SOGC guidelines today.
Right.
First, we looked at the nuanced trial and error biology of the hormonal arsenal, understanding why we have to change the locks instead of just using a different key, how add-back therapies protect our bones, and why we really have to contextualize side effect data.
Absolutely.
And second, we unpack the heavy values-based process of shared decision-making required before surgery. These guidelines, they aren't just a clinical textbook for doctors. They're a manifesto designed to empower you to demand a personalized approach to your care.
The medical system is deeply overwhelming, especially when you're dealing with chronic pain.
Definitely.
But armed with an understanding of how these mechanisms actually work, you can advocate for the standard of care these guidelines demand.
And as we wrap up this deep dive, I want to leave you with a final thought based on our discussion earlier about those bone density scans.
Yeah, earlier we talked about how DXA scans measure the quantity of bone, but are physically incapable of measuring the quality of the bone structure itself.
Right.
And that completely shifted how we interpreted that alarming side effect data. So it raises an important question for you to explore on your own.
What's that?
In a healthcare system entirely driven by raw data, test results, and chart numbers, how many other vital health metrics are we measuring with the wrong yardstick simply because it is the only tool we currently have?
Wow, that is a fascinating thing to think about next time you look at a lab result. Well, until next time, keep asking the hard questions, and we'll see you on the next deep dive.